I would now like to introduce our first speaker, Dr. Jerath. Dr. Jerath is a board-certified neurologist with outstanding credentials and a special interest in helping patients with hereditary motor and sensory neuropathies. She's a proud graduate of Harvard University, where she was an award-winning student and athlete. She earned her medical degree at the Mayo Clinic College of Medicine and returned to Harvard for her neurology residency. She next followed her husband to Iowa City, where she completed consecutive fellowships in neurophysiology and neuromuscular diseases, and earned a master's degree in translational biomedicine at the University of Iowa. Before moving to Central Florida to serve as a neuromuscular division director, Dr. Jerath served as director of the Charcot-Marie Tooth Association Center of Excellence and as a clinical assistant professor at the University of Florida. She has become a beloved favorite of our periodic paralysis patients struggling to find a diagnosis and has been a pioneer in this field, with us using telemedicine to see patients far and wide. We're looking forward to new things in the future with Dr. Jerath, and so I'm going to turn it over to her now. Just a minute.
Thanks, Linda. I'm trying to get my screen. So okay, share.
Okay.
And hello. Okay, so I want to share my slides. How do I go ahead and do that? Show my screen. Perfect. All right. So here we go. We've got a lot to talk about. And let me go ahead and start. Thank you for the warm introduction. All right, so let's get started. We have a lot to talk about in the next hour. So welcome to the Periodic Paralysis Association Conference. What an honor to be here. Thank you to Linda. Thank you to the PPA. I am blessed to be the medical director of neuromuscular medicine at Advent Health Orlando. That was formerly known as Florida Hospital, and it's a big hospital system in Florida, and it's been rebranded as Advent Health Orlando. And it's a great place to work with tremendous support for patients as well as research. So really blessed to be part of the program. So today we're going to start a journey. And as Linda alluded to, was that we are going to revolutionize and try to change the field of periodic paralysis and move it forward. Now, the journey began, of course, when I was in medical school and when I was in residency, but it also started last year in Orlando when I was just joined the Periodic Paralysis Association conference and sat in the audience. And in 1 year, I'm presenting, and I'm so blessed and so honored to be here today. I just can't thank you enough. The main topic of our discussion is that periodic paralysis is challenging, not just for patients and caretakers, but also for providers. And I want us all to enter this journey. And I want us all to discuss those variables of why it is challenging and how we can make things easier for everybody. So let's start this journey. So today's agenda is that we're going to discuss what is known, what is in textbooks. We're also going to discuss what is unknown, what is more challenging for patients, and is also very, very challenging for physicians. We're going to discuss treatment options as well as difficulties for patient care, and then we're going to conclude. I do want to direct everyone's attention to this photo. Now, this picture is a wave. This was a valuable picture of one of my mentors at the University of Iowa. I had a phenomenal experience there in Iowa. I learned so much from the giants in their field, including Dr. Michael Shai. I honestly tell you, I wouldn't be here without him. But here is Dr. Yamada. He kept this picture in his office. And you can see this wave. This represents like the old school thinking, and this is a digital transformation of this wave. And I feel that in periodic paralysis, we're going to have a transformation, not just in the periodic paralysis, but in a lot of the hereditary neuromuscular conditions. This picture, Dr. Yamada was one of the leading experts in epilepsy and EEG. He showed how much EEGs transformed over time. And I feel that in our current situation, neuromuscular medicine is going to be transforming, and we're going to go through some of those changes. So, but before we go through that, I want to tell everybody what is known. This first half is going to be more of a textbook lecture to actually understand what doctors are thinking when you walk into their office or into the ER, to see what has been written about periodic paralysis. What do we know in our textbooks? So all of the periodic paralyses, these are categorized as channelopathies. They are muscle channelopathies, and they involve ion channels. Just imagine for a second how hard that is to really understand. It may be easy to understand our eyes and our nose and our mouth because we see them, but we don't see ion channels very easily. So that makes the diagnosis, the presentation more challenging for everybody. Ion channels, you can see this picture here, they serve as the function of excitability of nerve and muscle memory. So they allow for different ions to go in and out of potassium, sodium, and calcium. And all the channelopathies are disorders that result from abnormal ion channel function. This abnormal flow, if you have that, can cause weakness or paralysis because the channels control whether a muscle contracts or relaxes. Here's a list of a lot of the ion channels. Here we have myotonia congenita, hyperkalemic periodic paralysis, paramyotonia congenita, the potassium aggravated myotonias, hypokalemic periodic paralysis, hypo and hyperkalemic periodic paralysis, and Anderson-Twill syndrome. You can see a lot of them have affected channels, chloride and sodium, calcium, so a lot of them repeat themselves. Here is another slide to just talk to outline what exactly we're going to discuss in the next few minutes. So we were going to talk about the hypokalemic periodic paralysis. There's a type 1 and a type 2. The hyperkalemic periodic paralysis, paramyotonia congenita, myotonia congenita, and Anderson-Twill syndrome. In general, a lot of these channelopathies have an autosomal dominant inheritance. For those people that don't understand that, that means that their condition is seen in every generation if it's passed on. So for example, if mom has it, then mom has a child, the child has a 50% chance of getting it. So, and then that child's child has a 50% chance of getting it. So if it gets passed on in each generation, it's possible. That's how autosomal dominant syndromes work. The onset for all of these are typically written in the textbooks first or second decade. Patients can get episodic attacks of flaccid weakness and feel very floppy and weak, which per textbook are often triggered by diet or rest after exercise. So a little more of our textbook definition. It's really helpful to understand what doctors have read about so that you can understand what they're thinking. So the hypokalemic periodic paralysis, those are disorders of the CACNA1X and SCN4A genes. The paralysis have early to late onset. The duration can last up to 20 hours. Not only can they have paralysis episodes that come and go, but then they can get fixed proximal weakness. So they can get weakness in their shoulders or their legs. They can, in the paralysis episodes, can be fully paralyzed or mildly paralyzed. Sometimes the heart or the cardiac arrhythmia can occur, or the lungs, people can have difficulty with breathing. Some patients will say, well, right before their attack, they'll feel numbness and tingling and fatigue and difficulty with thinking and behavioral changes just right before it occurs. They say sometimes that myotonia doesn't occur. The attacks are usually triggered by physical activity, a high carbohydrate diet, sodium intake, alcohol consumption, emotional stress, viral illness, and sometimes menstruation. Meds such as steroids or insulin can trigger the attacks. And acetazolamide, they've said in these textbooks, are helpful in some of the mutations like the CACNA1S mutation more than the SCN4A. And you'll see some of these descriptions will be repeated in our next few slides. I did want to discuss that there is a diagnostic criteria for the hypokalemic periodic paralysis. This is definitely old, but I want all of you who are listening in today who have this diagnosis to actually compare your notes. Do you fit this diagnostic criteria or you don't? Are there symptoms that you have that are different? And definitely send me a message or discuss this because it's important for this field to move forward, for us to figure out, is this criteria, does it include everyone? So the diagnostic criteria says here, 2 or more attacks of muscle weakness with documented potassium less than 3.5, 1 attack of muscle weakness in the patient, and 1 attack of weakness in one relative who also has to have a potassium less than 3.5 and at least 1 attack. 3 of the 6 clinical or laboratory features should also be present: onset in the first or second decade of life, a duration of attack greater than 2 hours, positive triggers, improvement with potassium, positive family history of a calcium or sodium channel mutation. And I can tell you, some of you are saying, wow, you may not have all of these. So that's why I brought this slide to the table. We have another condition, hyperkalemic periodic paralysis, but also the SCN4A gene. And attacks can occur in the first decade of life per our textbook. They can have myotonia, which is muscle contraction, no myotonia, or paramyotonia. Their symptoms can be worse with cooling. And triggers could be just the morning, rest after exercise, potassium-rich food, and then also stress. Paresthesias can also occur, so some people can have problems with numbness or tingling, and that's important prior to the episode. People can have achiness, they can have thigh and calf muscles involved. Episodes can last about 2 hours typically, and then sometimes when we tap on the reflexes, those can be diminished. Some people will have pain, and some people will have what we call proximal weakness over time. So they will have that weakness, which we discussed also in the hypokalemic periodic paralysis. Let's move on to these textbook, from these textbook definitions to another diagnostic hypokalemic periodic paralysis similar to the hypo. 2 or more attacks with a potassium greater than 4.5, an attack in a family member with a serum potassium greater than 4.5, as well as 1 attack of muscle weakness in the patient. So you could either have the patient having the documented attacks with potassium greater than 4.5, or a relative who's had it, as well as some of the 3 of the 6 clinical or lab features, such as onset before 3rd decade, duration of the attack less than 2 hours, positive triggers such as exercise and stress, myotonia, positive family history, or genetically confirmed sodium channel mutation. Paramyotonia congenita, this is another channelopathy with a mutation again on the sodium channel gene, that's SCN4A gene. Patients can have this with hypokalemic periodic paralysis. That makes sense because the gene is similar. Para just means it's paradoxical. So if they exercise, they get worse. They also get worse with cold. You can see the picture here, so that's not a great place for them to be, although it looks lovely. They can have focal or generalized attacks of weakness. So again, when they have weakness, it can be either focal, generalized. This is repeating what the other disorders had. They can also have the fixed progressive weakness, as well as paramyotonia seen in infants. And then speaking of that, you can see a young child here with myotonia. He has difficulty with opening his eyes. Myotonia congenita also is the SCN4A gene, as well as the CLCN1 gene. Patients will have difficulty opening their eyes. They have stiffness in their legs when walking. So they have just so much more muscle contraction, a lot of muscle pain, and they have difficulty with chewing and swallowing. Their symptoms also get worse with cold. They have mild weakness, approximately, but that varies. Sometimes if they have the SCN4A gene, they have a more painful variant. Here is an example of muscle hypertrophy. Hypertrophy, you can see how well defined the musculature is in this patient who is 22 years old and had a mutation in the SCN4A gene. He has very well developed muscles because he has myotonia, and the muscles are constantly contracting. And sometimes this is a helpful diagnostic clue for the diagnosis of myotonia. They describe him as very Herculean with a very well-developed musculature at a young age. Here is one of the last textbook syndromes I'm going to be talking about. It's called Anderson-Tawil syndrome. That's a mutation on the KCGN2 gene. And this involves periodic paralysis that is triggered by rest following exertion. I had a patient who would exercise and go outside and enjoy the day, and then he would enjoy his favorite recliner right after. And as soon as he rested in that recliner, he was completely paralyzed and out for hours, and nobody could figure this out. So it's rare, it's hard, it's a difficult diagnosis to make. Patients will also have cardiac issues such as ventricular arrhythmia associated with long QT syndrome. Patients will have skeletal developmental anomalies. You can see here a picture of that with a broad nose and a broad forehead, and sometimes they have a short stature. All right, so this is our slide to signal that we are moving on from the textbook to more of what Dr. Jerath or what I'm going to talk about. And my view of periodic paralysis, we're going to go from textbook to what we see in the future of periodic paralysis, a slightly more, maybe more current view, and I am blessed to have quite a few patients from across the country to get a different viewpoint of the periodic paralysis, and so we'll be transitioning to that right now. So this is my view. I have a picture here of how I see things in a different way than perhaps other physicians do. I believe that periodic paralysis is a spectrum. As I've already alluded to many times, these disorders, these channelopathies, have multiple genes that they share. So when I have a patient that comes in, I don't try to put them in a box. A lot of them will share similar symptoms of myotonia. A lot of them will share similar issues of paralysis or the need for potassium to make them feel better. Some will not respond to potassium, but that sort of spectrum is important to move this field forward. If we start, sometimes I feel if we put it in a box, not everyone will fit into a category. So it's hard to place every patient in a certain box, and not only is it hard because the diagnoses are hard and the channelopathies are hard, but every individual is different. I'm sure a lot of patients are shaking their head, oh yes, they are, and my patients are so different. But they share a common symptom of the paralyses. They all get paralyzed, that's episodic, but they have different presentations sometimes. I did want to throw in that the prevalence is pretty rare. A hypokalemic, it's 1 out of 100,000, is more common. Hyperkalemic is 1 out of 200,000, and Anderson-Tawil is much more rare, 1 out of 1 million. We are still learning. So this is the really crucial slide of my talk, because we don't know everything about periodic paralysis yet. Just imagine those patients that had symptoms about 20 years ago. I have heard stories from my patients that their grandfather or grandmother were thrown into insane asylums because they would get all upset and then they would get paralyzed. And so physicians had no idea what was going on. And so periodic paralysis at least has improved and moved forward over the years, but we still have a long way to go where we don't really know much about these conditions. It's rare and they're hard to diagnose. So one of the things I'm going to start off that we are still learning is that patients don't always need to have potassium being high or low. And you can see that diagnostic criteria, that how physicians think that the potassium always has to be high or low for the diagnosis. And I am on the phone all the time with an ER doctor trying to explain this concept. So there is the condition, of course, normal kalemic periodic paralysis. That does cause similar symptoms. We have a lot of knowledge gap in the mutations. And I know Dr. Cannon, who will be speaking later, is an expert in this. But just for instance, the RYR1 mutation is new, and it produces overlap syndromes. It produces new symptoms that we're learning about. So that in and of itself, it makes the diagnosis challenging. There are many more genes that we don't know about. One of the other things we're still learning is the text can be long. We say 20 hours. If you read the textbook, I have patients that have had texts for much longer than that. Myotonia and paralysis can potentially alternate in episodes that look like seizures. And that, to me, I'm very passionate in bringing to the table and bringing physicians to learn more about that condition. I had a few patients who was very intrigued by this, that when they come to my clinic, they'll have this myotonia, where they'll have muscle contractions, and then just flaccid paralysis right after. And when we think of periodic paralysis, we just think of just paralysis, right, in the textbooks. But sometimes myotonia or muscle contractions can alternate with that, with the paralysis episodes. And so a lot of physicians, a lot of ER doctors will say, okay, well, is this a seizure? Because that looks like a seizure, but the patient is talking through it. Okay, then they go into saying, well, this is conversion, or this is psychiatric. And so it's a confusion. I think these type of episodes really need to be, we need to learn more about it, and physicians need to learn more about it. We need to understand them a lot better. But you can just imagine if it's a channelopathy, that sometimes the muscles are contracting too much, and then sometimes they let go in paralysis. So that's my hypothesis on that. There are a lot of patients with unknown treatments. This is really hard because patients were so excited to get a diagnosis, and all of a sudden they're sensitive. We don't even know how much potassium what the long-term side effects are of potassium. And so we have that as an unknown. And some people are just so sensitive to medications that we offer. And that makes things quite challenging as well. We did discuss pain in the textbook, but what I'm discussing is not just the simple pain. I am talking about excruciating pain. This is pain that my patients say, Dr. Jerath, I don't want to live anymore kind of pain. Pain that makes them run to the ER every 2 weeks or even sooner. And doctors, again, don't understand that. That is a really important part of how we want to revolutionize the field, because we want to make sure that people understand this is not an easy diagnosis. If someone's hand gets cut off, yes, that could be painful, we see it, but people don't see the excruciating pain in the channelopathy. But can you imagine if the muscles are contracting all day? That is painful. Some have migraines before their episodes, again, that can distract physicians to think this is a migraine. Some people can have spasms in their throat or diaphragm muscle, so again, that's a diagnostic challenge because people don't understand that. And some can have a later onset than what's true. This is an important paper for me. Some of you may recognize this paper. This was written by our cherished scientist and physician, Dr. Lehman Horn, in 2013 about a family who had a transient compartment-like syndrome and normal kalemic periodic paralysis due to a calcium channel mutation. So again, this is a periodic paralysis with normal potassium. The family was known to have cramping and weakness. They also had muscle weakness, a progressive myopathy, and triggers were cold cold as well as rest after exercise. So I wanted to just have a thought experiment for just a second about this paper. Just imagine what this family had to go through when before this paper was published. Just imagine the uphill battle to get treatment, to get an understanding of the disease. So if we think for a few seconds of how this poor family had to struggle to get a diagnosis, and they finally found someone who helped them, just imagine what you're going through right now. If you are having trouble with a diagnosis, if you don't have a mutation yet, it's okay, because we still don't know a lot. Just in 2013, we're publishing about periodic paralysis. It's 2020. We have a lot to learn. We have a lot of genes to discover and a lot to understand about this condition. So I feel bad that this family had to go through so much, but at the same time, we found an answer. So that's what our goal is today, is to move the field forward and to learn more about these periodic paralyses. So another thing that we're learning are the new genes. I was fascinated with the RYR1 gene. It can cause many different conditions, including hereditary muscle disease. But there was a paper in 2018 that illustrates how it can cause a late onset atypical periodic paralysis with and without associated muscle myopathy or muscle weakness. So some can have muscle weakness and some can't. There is no consistent relationship to food or temperature across all these cases, and many of them have muscle pain or cramps that are predominant. One of the things I do want to say is that just in the last few weeks, I've had a few patients with this, and they have different presentations. So it's really important that we collect this data and learn more about these mutations. This is a slide of those cases in this paper written in 2018 in the Neurology Journal. I really do want everyone to see this from a bigger picture point of view. Look at this case 1. The onset was at age 34 years, so it was a later onset. Case 2 was also 23 years. That's when the episodic weakness occurred. And case 3 was 14 years. So most of them were a little bit later onset than usual. But what is really interesting about this chart is none of these things are the same. So the examinations are different. The CK is a little different variable. And EMGs, of course, we see 2 normal, right? And then 2 with myopathic changes or muscle disease changes. The McManus test, which is another indicator for periodic paralysis, is positive in only 3, not the 4th one. So these symptoms and the workup are not all the same. Can you imagine how hard it is to diagnose these kind of patients? Even a muscle biopsy is not all the same in the patients, but everyone does have a variant in RYR1, and everyone does have episodic weakness. And that's why I feel like we should push towards improving our diagnostic criteria so patients can get the treatment they need and we can understand this disease a little bit better. Here, I had one of my favorite patients. She had an SCN4A mutation. She had prolonged attacks in hyperkalemic periodic paralysis. Can you imagine? She's a young woman. Her episodes last from weeks to months. She's had a million episodes of muscle cramping. Her scalp, her vaginal area, every muscle cramp all day. And that just brings tears to my eyes. I don't know how she manages that and how she tolerates that. But she has breathing difficulties. As of the last year and a half, she has had muscle weakness and burning. And she has burning in her deltoid and quads. And when she brushes her teeth and puts on mascara, she used to take a lot of breaks. It needs a lot of time. And it's very painful. We did try to treat her with baclofen with a little bit of improvement, but it's still been difficult with allergies and so many other issues that we have to deal with. I do want to talk about some unique characteristics of pathogenic mutations. All these patients had paralysis episodes. So we did have a pathogenic mutation in these genes. All of them had paralysis episodes, but they all had interesting features to their presentation. For the CLCN1 gene, this patient had hand cramps. Can you imagine the physician who sees the hand cramps? The first thing they think of is This could be carpal tunnel or something else. So that's not an easy presentation or something that we can figure out right off the bat. The next gene mutation we have here is that the patient had digestive pain, bladder emptying difficulties, paralysis episodes that last 5 to 6 months, cramping and leg swelling. That in and of itself is a diagnostic challenge. And so patients like that have a very difficult time finding out what's wrong with them. We have another patient here who had normal K-limic periodic paralysis, and the potassium was normal. This patient had burning pain in their arms and paralysis after headaches. Nobody could understand what was going on. The headaches threw physicians off, the burning pain, nobody understood. The STM4A mutations, patients have chest pain, throat pain, and pain. There's a patient who had that pain worse than menstrual cycle, and that was unusual. She also had difficulty with diagnosis as well as treatment. So here is another mutation found in 2013. It's a novel ATP1A2 mutation in a patient with hypokalemic periodic paralysis, but also its central nervous system symptoms. So this was a child who had hypokalemic periodic paralysis, but also developed seizures as well. And then they discussed that this gene could be linked to the hemiplegic monitoring. Now, I do get questions in my clinic all the time. I am so honored to be able to try to answer them. One of my patients asked me, Dr. Jerath, could this be myasthenia? And you know, my answer was, it depends. I'm not sure. We have to investigate. So here is a patient who in myasthenia classically has eye droopiness or difficulty with eye opening. That's called ptosis. And here's a video of a patient who had the myotonic lid lag sign. She was trying to look down and it took a while for her eyes to close. And then she also had difficulty when she closed her eyes to open up her eyes. And you see here that she had what could look like a droopy eyelids and ptosis. For those patients who feel that they have these symptoms, that is myasthenia. I see this in my clinic quite a bit, but I just wanted to illustrate that. But then that's why I say it depends, because there are cases where there is myasthenia gravis. There was a young woman who was written about in 2019. She had severe muscle weakness, difficulty with breathing, and hypokalemia. She was intubated. So as soon as she came to the ER, she had to get a tube down because she couldn't breathe. And the doctor saw that her potassium was low, so they normalized it. And she improved. Her arms started working, her legs started working, but she continued to have difficulty with breathing. So what the doctors remarkably did was they actually checked for another disorder. And they checked the acetylcholine receptor antibody, and that was positive. So there was a diagnosis for her, as she had myasthenia gravis and hypokalemic periodic paralysis. She improved. She got the tube out after they treated her for the myasthenia. So they gave her mestinon and steroids and plasmapheresis. And so it's important for those patients who have difficulty with improving their weakness. It's always important to look for a second disorder to make sure that, even if potassium is improved and if they're still weak, it's important to look for something else. So when patients ask me, is this myasthenia gravis, Dr. Jerath? It depends. We have to evaluate. We have to know everybody's story. So I have had these questions as well: pregnancy and periodic paralysis. And this is where we really are lacking in terms of knowledge. There are mixed results, but they're just individual case reports. So when I was searching this, there were cases that said that pregnancy can worsen hyperkalemic periodic paralysis. There was a case report where menstruation pregnancy can worsen the hypokalemic periodic paralysis. And then you have a whole case report here where a patient with hyperkalemic periodic paralysis got better. during pregnancy. She would have one attack a week when she wasn't pregnant, and then when she was, she had only a few mild attacks and 4 severe attacks that occurred. And then as soon as she delivered the baby, she started going back to her frequent attacks every week. So this is a very hard topic. It's variable. We don't really know very much about it. Some of my patients ask me, why, Dr. Jerath, am I so sensitive to colds? I can tell you right after that, Dr. Cannon knows this so much better than I do in terms of the physiology about it, and I know he wrote a paper on this. But the easy answer is that the extreme cold can just affect how that ion channel functions. And if you want a more academic answer, sometimes that cold temperature can just destabilize the slow inactivation as well as the fast inactivation, and that just can cause the membrane to be depolarized, and it's really hard for that membrane to be excitable and for muscle activity to occur. So that's a more academic answer. There are probably a lot more details to that, but just essentially the extreme colds can affect how that ion channel functions. The reason why I bring this video into the picture is because I want to say that we are still learning, and I want to really encourage all the physicians, all the caretakers, all the family members, all the patients to really, and of course the patients have the most open mind, but everyone else who really has to support our patients, it really should just have an open mind. And we can learn a little bit about this horse who has hyperkalemic periodic cough. And you can see here the muscle contractions. And we'll let this video run for just a couple of minutes. And you can see that here.
It is believed to be a natural mutation that occurred as a result of evolution. However, it became widespread as a result of breeders' desires to produce horses with heavy muscles. And as we all know, the American quarter horse is very famous for its athleticism and well-muscled beauty. Impressive was an exceptional horse and the first horse in his breed to become an AQHA world champion, open age halter stallion. It is his muscular and refined form that led him to sire 2,250 foals and about 55,000 living descendants as of 2003. I find it very interesting that Impressive never showed any symptoms of the HYP disease. However, all horses, I repeat, all horses with the disease have been traced back to this stallion, Impressive. What makes it even more interesting is the fact that HYP is an autosomal dominant mutation. It requires only one parent to have the gene and pass it on to the offspring, and it does not skip generations. One homozygous parent will result in all offspring carrying the defective gene. So while it may seem that some horses exhibit little to no signs of the disease, it is not possible for it to get diluted, in quote, contrary to what some people might believe. However, some affected horses show little to no signs or symptoms through their lifetime, while some others experience it frequently. HYPB is known to be triggered by high potassium levels in the blood, also known as hypokalemia, stress, general anesthesia, lack of exercise, or concurrent illness. Research has also shown that younger horses tend to experience more attacks than older ones, but reasons for this remain unknown. Based on these triggers, some methods of preventing HYPP attacks are to feed your horse several times a day, because lack of food for long periods of time can cause their potassium levels to spike up in a situation where they are fed those potassium-rich foods.
So that is an important video for me, because that just describes how difficult it is to detect mutation in horses, and there are diagnostic challenges just with these channelopathies in general. So we're going to move on to the next. I'm sorry. So this video is one of my favorites. Now I apologize if you have really gone to the Periodic Paralysis Association website and have seen these videos. And apologies ahead of time, some of this is old for some of our viewers. But I do want to illustrate how important it is for us to recognize these attacks, for us to understand them better. I do want to say that there is, for those that don't know about this website and the resources, that this is a great video to show doctors what attacks do look like, because I don't think physicians really see that frequently. And this is just eye-opening and a very great educational tool also to show for caregivers. And so I really appreciated this video. We're going to watch a few minutes, if that's okay, to get a sense of the attacks. And when you're watching it, I do want you to look at it from the lens of a doctor or a caretaker, because the attacks are hard. I mean, there's not complete paralysis, sometimes it's halfway. And so some people just don't understand these attacks. So let's go ahead and show this one.
This is a true attack of familial hyperkalemic periodic paralysis. Triggers for this attack were a high carbohydrate meal and exercise without pre-medication. The patient in this video is a physician and is being analytical through the attack. This attack was amongst the most severe he has had. He is able to speak and is going to lead you through what it's like to be paralyzed.
I've woken up and I'm paralyzed. The first thing that I do is try to figure out how severe is the attack. I have my arms, but my hands are very weak, so it's really, I can't even open a bottle of water right now, so that means I can't put my medicine in the water, so that's a problem. And, you know, so now I need to basically call for help because it can only potentially get worse. Well, hopefully I don't have to go to the bathroom, first of all. Sometimes I wake up and I have a little more movement, and so then I can make it to the bathroom, make it to the medicine, call for help, plop back into bed. For some reason, I woke up and I was too paralyzed to do that. So I just have to lie here and basically wait for someone to find me. Once it resolves, I'm gonna need to sleep it off because all my muscles are gonna feel like they're torn up, like I just did a big weightlifting exercise. And then of course you go to work late. People aren't gonna believe you because they don't understand what this is. Luckily, I can, you know, kind of sort of get to my side, and I probably want to stay on my side at this point if I can even feel the remote possibility of throwing up, because then at least I won't choke to death.
Typically, individuals who suffer from periodic paralysis have medication, sometimes pre-mixed, at the bedside, and a phone or other means of calling for help. Here we see typical efforts at movement with a great degree of difficulty. When one attempts this alone, injury, like a twisted ankle, can easily occur.
What's worse now is I fell asleep over the covers and it's cold, and the cold just makes it worse. So ideally, I'd like to be covered, and I can't even cover myself right now. I'm just stuck here. I really can't move anything right now at all. I'm very severely paralyzed, so I really need you to pull my arm up. You gotta pull my right hand towards the mirror. You're gonna have to get towards that side because you need leverage. And then, Frank, you're gonna get my leg.
Having a cooperative individual to lend assistance is key. Subtle angles create pressure on joints. The patient is using ergonomic angles to support himself. It is his joints, not muscles, that are supporting the patient. There are risks of moving someone while paralyzed. It can hurt or injure the patient, especially if they are non-verbal. Moving a patient must be decided upon a case-by-case basis. Note that the patient in the video is dependent on the people around him for both physical and psychological support.
Okay, now I need to get the medicine. So you see, I can talk and I can breathe, but I can't move, and this is extremely distressing.
The patient is now taking potassium chloride dissolved in water in an effort to reverse the attack.
At least I have my neck. Sometimes I don't have my neck, and then I'm really stuck. And I think that will happen to me if I don't have the medicine in me. Now, if I drink this fast, what happens is you can get a gas bubble, a sensation that you want to throw up or burp or something. And so I just have to let it happen.
Dosing varies from patient to patient. The patient is taking his prescribed amount.
I think little by little it doesn't work. I need to get a bunch of potassium in the bloodstream quickly to reverse what's going on with the ion channels. Some people underdose themselves and they'll be in this condition for longer than necessary. Now it's extremely tiring for me to stay up like this. At the same time, I don't want to lie down. So what I need to do is can you adjust my feet so that they're both on the floor? And then I want to put my elbows on my knees. And let me lean forward a little bit. Okay, this is kind of okay. See, there's no position that's comfortable right now, unfortunately. So now I'm home, and I'd like to put my arms so I can.
Here, the attack is getting worse, as seen by more labored speech and troubled disposition.
I want to lean on Frank. So pull me back up. And let me lean forward a little bit. And let me lean on Frank.
So that's an emotional video because that's really hard to see, and to see how things got worse. And I think he had stomach pain right after that. But for those that want to be able to see more about that video and more about periodic paralysis, definitely go on that website. And if you feel that your physicians don't know and you haven't given them my cell phone, definitely show them a video in the clinic because they may not really understand it. So Dr. Levitt wrote this first paper in 2008, and I came across these questions. I did edit a few. I took a few questions that I thought were important, and I added a few of my own. So we really still have not studied as much as we should. So we don't really know who gets permanently weak in the periodic paralysis. Are there risks to chronic potassium administration? We're still learning about that. Does a particular form of potassium work better than another for this disease? And I do tell my patients each individual is different. Some of my patients ask about massage, and does massage make things worse? For some it helps, for some it does not. And so again, that's very dependent on each individual. And should we revise our diagnostic criteria? And that's something that I brought up to the table and I will bring up because things are changing. We need clinical trials, larger groups of patients to come together to answer these questions, plus many other questions that are still unanswered. I'm going to go through a list of the treatments for myotonia and periodic paralysis. You can always come back to the slide regarding doses. So for myotonia, we try things like mexiletine, lamotrigine, acetazolamide, carbamazepine, flecainide, and ranolazine. For the periodic paralyses, we offer things like acetazolamide, diclofenac, also known as Keveyis. And for the hypokalemic periodic paralysis, we try them on potassium-sparing diuretics like spironolactone, amiloride, and triamcinolone. The thiazide diuretics are used for the hyperkalemic periodic paralysis. Those include hydrochloric thiazide and bendoflumethiazide. And then, of course, the potassium supplementation, which can vary from IV supplementation, oral supplementation, and also some patients take it in the form of a drink, or they mix it with water. I do tell my patients, and they've told me, and some of them come up with coconut water, and I tell them also if they don't drink it. For those that are hypokalemic, coconut water is an excellent source of a beverage to help with their potassium. I also encourage fresh squeezed orange juice, not the store-bought, that can be high in calories, but anything that's fresh squeezed usually is pretty safe, and it can help also with potassium. I love exercise, but none of my patients are routinely referred to physical therapy unless they ask for it. Physical therapy can definitely help in terms of helping patients with their limits. and knowing how much they can do. But exercise or rest after exercise can be a major trigger of myotonia or the paralysis. And activity is important. So it's really important to balance that activity without triggering symptoms. So some things that have been done in the past are endurance training with a bike, 30 minutes, 3 times a week, which can be helpful. It's really important not to have a sudden contraction or forceful contraction that can trigger the paralysis or the symptoms of myotonia. But just to be very, very gradual. It's okay to have rest periods. It's important to avoid cold and avoid swimming in cold water. Another thing to think about is considering yoga, because yoga has gentle stretching. I know one patient really loves yoga and is doing very well with it. Meditation is important. Stress can exacerbate everything, and of course, our periodic paralysis, our intolerant channelopathies. And some of the meditation techniques out there include mindful meditation that involves being fully present in the moment, in engaging in all the 5 senses and really enjoying every single second and taking away the thoughts that are not relevant for the moment. So that includes focusing on sound and sight and taste and smell and touch. And this meditation helps people not to be overly reactive or to be distracted. This is an important slide as we start wrapping up this talk. Our patients, as I've been saying since the beginning, are going through an uphill battle. Not only is this disease rare, but it's unique. Everybody has different stories. Everyone is different in some way. Patients can have pain. We don't know all the genes. The physicians, you can see how they can get confused. They're still learning. There's a lot of unknowns and variables. And the patients just trying to get help, just to get the medical care they need. They are suffering with the disease, and then on top of that, going through all these uphill battles to get the help they need. And it becomes hard. It becomes hard on everyone, the patients and the physicians and the families and the caretakers. What we want is we want to have a nice ride, a very pleasant ride. We don't want any more uphill battles. And in order to move this field forward, we need your help. We need to work together. And that's one of the major strategies we have in our clinic, is that we work together as a team to learn more about the condition. Not everyone may have a diagnosis, but we try to help in any way possible. We try to help find new genes. We try to help figure out the problem. We will redefine things together. We'll raise more awareness and understanding of the conditions together. And so that's very important. So I do want to thank you all. This is our team. We have a clinical team and our administrative team and a mix of both. We wouldn't be here. I wouldn't be here speaking today without them, of course, my family at home, and they've been so supportive, and my family at work. They're just wonderful. I wanted to thank you all. We would love to see you at Advent Health Orlando. We do want to work with you to build a center of excellence for you. They'll care for all your needs. We want to take care of you. We're just honored and blessed to be able to have that opportunity. We have already patients from 22 states outside of Florida. If your state is not put on here, please let me know. Text me and say, I don't think I forgot any state, but if I did, just let me know. But we are really blessed to have patients from all over the country get virtual visits, some of them fly in, and we're just more than honored and thrilled to be of any sort of service to help in any way possible. I really want to thank all of you. I want to thank, of course, Linda Feld, who means the world to me, has done so much for us. The Periodic Paralysis Association, they have been wonderful. Every single one, and the board members are excellent, those whom I know. The Strongbridge Pharmaceuticals has been supportive, and all my patients. I've never enjoyed doing this more than anything else. I'm just so grateful for all of you. And I'm grateful for all the listeners here today. And I would love to answer questions. I know that there will be questions at 3 p.m. And I will try to participate in that. So Linda, thank you.
Thanks a lot, Dr. Jerath. That was wonderful. And I can ask you a couple of the questions that have come in while you have been talking. And we're building up a lot of questions here. Dr. Jerath, this is, I don't know who sent this in, but it says, Dr. Jerath, I have had severe episodes of slowly contracting muscles, usually starting in my legs, to the point of not being able to walk since I am 5. I am currently 72 years old. I have to move my screen down a little. These happen in conditions of a combination of humidity, walking, excitement, and a change in diet. I know how to manage usually, but sometimes these conditions are unavoidable. I don't fit into any category completely. I have read about, I'm not aware of other relatives with this. The question is, as I age, it is even more important to get a diagnosis and to know the exact reason for these episodes. I haven't told my current doctors about this condition, and I don't know how to describe it. In the past, the doctors have not taken me seriously since I don't fit any category easily. How should I proceed? What kind of doctor should I consult? And how should I discuss with my primary doctor so that she will understand? Thank you so much.
Oh, I just love that question. Thank you. We would love to see you in our clinic, and even if you have to do a virtual appointment, I would love to help you figure out what's wrong. And we can discuss strategies on next steps and how to help you with your diagnosis. I also discuss, and I'm always on the phone with physicians, helping them understand. So even if it's a primary care physician, I can help, and I can help educate you as well. So I'll be there for you. If you need to come visit, please make an appointment.
We have another question from Julie. Dr. Jerath, how do we know the difference between periodic paralysis and hemiplegic migraine? I have been diagnosed with the migraine, but it's totally refractory, and my symptoms fit many aspects of PP also. There is so much crossover in symptoms, it seems.
That's an excellent question, and I feel like there will be crossover into the symptoms at some point. But I think that getting your history, I don't have all your history, but getting your history is important. Also, maybe trying potassium to see if that will help you. Sometimes helps with the diagnosis. Of course, genetic testing will help, but starting off with a history is probably the most important thing to distinguish between a hemiplegic migraine and periodic paralysis. Because if you're getting migraines independent of the weakness, and the weakness or paralysis episodes are separate, they may be two separate things. So it's important to spend a lot of time with the history. And that's where I would start. If you want to, again, see me in the clinic, I'd love to help you.
We have a question from Janine, and she's asking about alternating myotonia and paralysis that you're talking about. And she'd like to know, is that the same as myoclonic jerking? This happens to her, and she's learned in the ER that the treatment for it is to be wrapped in heated blankets.
So these things are very hard to detect. I think the myotonia and the myoclonic jerking have to be investigated with certain diagnostic testing during the time it occurs. These are hard. So myotonia is where you have muscle contraction, and then you have myoclonic jerking, which is more of a rhythmic contraction. So you need not only diagnostic testing, sometimes some people will do an EEG to see if the myoclonic jerking is associated with seizures, and then also have a clinician look at it to really distinguish clinically what's going on during those episodes. So these are hard to distinguish. They just need a lot of care. One of the things I do recommend for you is to videotape them. And if you videotape them, sometimes some expert from across the country or the world can help weigh in on their opinion so you can distinguish the two.
And let's go with one more, Dr. Jerath. This is from Allison, and she's asking, those with excruciating pain, how do they get treatment without being seen as a drug seeker, and how do they get taken seriously?
That's a brilliant question, because that's something I have to deal with almost every week. I'm on the phone with an ER doctor who doesn't believe the patient. Oh, she's coming again. It's that attitude that you have to deal with for some of the physicians across the country who don't understand. So some of the strategies that you can take are, of course, finding a physician who will back for you. I would love to help you out. Number two is that some of my patients have written letters to the ER doctors, have letters signed by a physician who's going to support you. The letters will say, regarding this patient has this, and I assume, I don't know if you have a diagnosis of puriatic paralysis or a myotonia, but some of my patients say, okay, they have this channelopathy, they have this known mutation, and they will experience pain, and for this pain, they need these next steps to be taken. And that really helps our patients get the care they need. So it's important to get a physician who's going to understand it, and then as well get a letter that will help you. And then if that doesn't help, and you go to some unusual ER that doesn't know you at all, then my patients immediately give myself up. So I know that I've used to help my patients, but not everybody has that ability to get a doctor to give their cell phone and respond at all hours, at 9 o'clock on Friday, sometimes 3 a.m. in the morning. It is any time. I'm so grateful to be in this position to help, but I'm really writing a letter, getting a letter from a physician, that can help you.
Well, thank you so much. Dr. Jerath is my doctor, and I can't say enough about her. I think she is wonderful. Thank you so much for being here today. And we're going to be changing presenters now. And the next presenter is going to be Laura Russell, who also works with Dr. Jerath in her office. So we'll see you later this afternoon, Dr. Jerath, when Dr. Cannon is answering questions.
Perfect. Thank you so much, Linda.
You're welcome.